Hi, I'm Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
I got it, buddy. Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. And this week, I have a question for you, the audience. Could you imagine having a football team with not just one quarterback, but 5 quarterbacks, calling the plays, each play, each one calling a different play? How do you think that team would perform without one leader? Not too well, I would suppose. Everybody would be running here and there and there and there, banging into each other, and no one would be able to accomplish any goals. In our current healthcare environment, it's quite common where patients see multiple different types of specialists and doctors. Each one having their own approach, each one possibly doing different testing, each one probably having different interpretations of those testing, and very often you, the patient, are confused and say to yourself, who the heck do I believe? What should I do? I read in today's Newsday, there was an article about diagnoses. And it's estimated by the AMA research that at least one out of every 3 or 4 diagnoses is incorrect. That's pretty amazing, because when you make a diagnosis, you then institute a treatment plan based on that diagnosis, and if 25 to 33% of them are incorrect, you're receiving treatment for something you don't need treatment for, and missing something that you should have treatment for. So, communication, coordination. That is the key to a successful patient-doctor relationship. In our facilities, in Melville, in Ronkonkoma, and in Hicksville, we have assembled a team of specialists in many different disciplines. And if they're not there, we have relationships with other disciplines in other facilities where we can freely walk in and discuss a case we're having with a patient. Perfect example is I had a patient last week. We did an MRI on the patient. MRI was a little questionable, the report. So I looked at it myself and I found a herniated disc which wasn't seen. I then brought that MRI film to a radiologist colleague, good friend of mine, and we looked at that together. And he agreed with me that the herniation was there. And it's extremely important when I'm putting my hands on patients to know where these things are, to know where the injuries are. So number 1, I can help the patient. And number 2, I don't hurt the patient. That's even more important to me. So in our facilities, all the specialists talk to each other, sometimes on a daily basis. They're there right with us. I take an x-ray, I bring it to the orthopedist. What do you think, doc? The physical therapist is treating someone, the orthopedist goes over to the physical therapist and says, I'd rather see you do a little more of this or a little more of that. So there's real coordination within our facilities. And that benefits the patient because you can get the best a la carte off the menu of what every discipline has to offer. Now, each week I have a specialist from a different discipline here as my guest. Today I have the great pleasure and I'm looking forward to a meeting with my good friend, Dr. James Lambert. Hi, Dr. Lambert.
Thanks for having me.
Welcome. Thanks for coming down. Dr. Lambert, tell the audience a little bit about yourself, where you went to school, when you graduated, what your specialties are, things like that.
I actually grew up on Long Island. I grew up in Ronkonkoma, where I practice today. Went to Kennequot High School, went to undergraduate up at SUNY Brockport. From there, I was pre-med when I was there, ended up getting an interest in chiropractic. Went to chiropractic college at the National College of Chiropractic out near Chicago. Spent about 5 years out there. Came back to my hometown and opened up my practice, and I've been in that area for the last 30-some years now.
Great, great. And now you're just not a chiropractor in an office just doing chiropractic, right?
No, for the first couple of years maybe, but I soon found out that it's, if I wanted the best outcomes for my patients, if I wanted to, control healthcare costs for those patients and stuff, it just made sense to work in an integrated facility.
So in your facility, tell us, we work within your facility, and we see our own patient base, you see your own patient base. Tell us about the different specialties you have in there that are right there that you can consult with your patients.
We've always had physical therapy with us, because physical therapy, chiropractic, I've always felt goes hand in hand. We've had a bunch of different medical doctors, different specialties, ranging from physiatry, neurology in the past, orthopedics, an osteopath to give that slant to it. We still have acupuncture, massage therapy, nutritionist, all working together. It just makes a lot more sense that way, it seems to me.
Right, right. And let's make it clear to the audience that you as a chiropractor practice chiropractic.
Correct.
All the other specialties, they practice their own disciplines. They are simply people who occupy space in your facility, and they make their own medical decisions, you make your own, and you guys work together, right?
Right. The beauty of this is that, we'll have the patient will come in, and, I may be the quarterback, like you pointed out earlier. I thought it was a great analogy. I may be the quarterback on a case, but I have the availability right there to get some input from the medical doctors, have them see it. Maybe they can add something to the case, to speed up the patient's outcome. Right. I can get the physical therapy working on some stabilization or strengthening and stuff on top of what I do.
Right.
But yes, we practice independently, but it's nice to have it right there. The patient's not going across town and going all over the place. They're saving time,
right,
saving money, and better outcomes.
Right.
That's what it comes down to.
And you're talking to the specialists.
Yeah.
So you're not repeating care, it's not redundant care, it's not care that someone else is doing that will interfere with what you're doing.
Correct.
Et cetera, right?
You mentioned earlier communication. If we didn't have those lines of communication open, the amount of, the length of time that it would take to get that patient better would definitely be expanded, because,
right,
we could be like doing things that are, making each other's problems a lot worse. Working together makes a lot more sense.
I did a show a few weeks ago, and what I brought out to everyone was that our job as chiropractors is to correct subluxations where bones move out of place. They affect the nerve flow in the area, which leads to symptoms, and our job is to get those bones back into place. And I had in my conversation, I explained to the audience that if I've now got a subluxation out of place, and the patient's just doing PT and strengthening, and nothing else, they're actually strengthening a bone that's out of place, pinching a nerve.
Right. Exactly.
Likewise, if the chiro adjusts the bone and gets it back into place, but never does anything to fortify the new structure,
the patient's going to have that same problem.
It'll keep having to go forever and ever and ever and ever, and chronic recurrent problems, where if you use both together, you have the optimal outcome.
Definitely, without a doubt. It's and you've been in practice a long time, I know, and I've
not that long.
Well, we let's just say 30 plus years.
32
for both
years.
Of us. Oh boy. So in that time, we've all seen those cases that if we were just out there alone treating the patient, they would not have as good an outcome or as quick an outcome. So it definitely makes a lot more sense.
Okay, so I ended my last show on soft tissue injury, what it is, what different types of collisions are, elastic, plastic collisions, how the patient in the vehicle moves back and forth and how they get injured, and the different dynamics of what happens inside the vehicle. And we left off with careful history and consultation. We left off with a thorough clinical examination and then diagnostic testing. So we're going to start today on the diagnostic tests that are available out there to document and show these soft tissue injuries. Because as I told you, the audience, last time I was on the show, for years, fractures were very easy to document, and they still are. If a bone's broken, it's broken. We take an x-ray, we do a CAT scan, and it's vivid. You can see it. Either the bone's cracked or the bone is not together anymore. Soft tissue injury, on the other hand, sprains of ligaments, sprains of, strains of muscles. Until very recently, they haven't been that easy to see, but with the new technology we have, It's a lot easier now. And what I want to talk with you about today is something that you're kind of like focused on now and have a great expertise in, and that's ligament injury.
Correct.
Right.
Go ahead, I'm sorry.
So tell us a little bit, tell the audience a little bit about what is a ligament and what does it do?
A ligament is nothing more than, it's something that ties one bone to another bone. You know, without ligaments, we'd be a bag of bones. We wouldn't have that structure and support. They're very important not just for stability, but also for there are things called mechanoreceptors and nociceptors. Mechanoreceptors are like pressure sensors. They're inside the joints and inside the ligaments, and they give the body constant feedback. If your head gets shifted to the left, there's mechano or pressure receptors in there that give feedback to your muscles in that area, saying that you got to strengthen up, you got to resist this type of motion, or you have to provide the body a little bit more support because of it. Nociceptors are like pain receptors. We all know what they are. If you touch a hot stove, you're going to pull away pretty quick. And those nociceptors and mechanoreceptors are they work non-stop in healthy tissue, constantly giving the brain and the body and the spinal cord feedback. So when you injure the ligament, you're not getting 100%. They're not working function as they should.
Right.
So.
And as I explained on my last show, that every joint in your body has ligaments holding those two bones together. There's ligaments between your femur and your tibia and your knee. There's ligaments between each bone of your fingers. And those ligaments are designed to stabilize the joint so the joint moves normally.
Correct.
So when that ligament the term is sprained, and there's all different grades of sprain, from grade 1 all the way up to a 4, which is very severe. I explained also to the audience, it's kind of like a new rubber band getting stretched out and getting old. It doesn't have the elasticity or the holding ability that the new rubber band had. And so as a result of that, those joint structures, they now, when the person moves, they now slide on each other, and the cartilage between those structures wears out. And a lot of damage occurs due to that instability.
Correct. Yep.
So, patient has a rear end collision.
Mm-hmm.
They go through a whiplash injury. The head flies back, the head flies forward. Certain ligaments in the spine become injured, correct? Or can become injured?
Yes, they can become. They don't always, but they can be. But the doctor, the treating physician, needs to know, obviously, which ones are injured and to what degree they're injured.
Right. And MRI normally doesn't show these injuries, correct?
The technology with MRI has improved drastically in the last couple of years, but it's not quite there yet where it can actually look at the damaged tissue.
Right.
It can see the result of the damaged tissue, maybe some increased swelling in the area or whatnot, but it's not going to see the actually torn ligament, so it's not quite there yet.
The analogy I give my patients a lot is I can take a pen and I can take an x-ray of a pen, and I can see that I have a pen, but I don't know if it works.
That's great.
Whereas if I take that pen and now draw to see if it works or not, static x-ray of a patient without just looking at bones, which are called static films and not stress or functional films, just tells us if the bones are there or if the bones are fractured or there's any pathology in them. The only way that we're going to know if there's ligament damage and that those bones are moving the way they're supposed to is to do what's called a functional x-ray analysis, in which we're going to now put the patient's head in different positions. Why don't you describe to the audience what these different positions are and what we're looking for?
Okay. The most simple ones, we'll talk about the neck first. The most simple view is to take a lateral, a neutral lateral. And that's with it. If you're looking at my neck, the x-ray would be coming through here, and you'd see the neck from the side. The other two views associated with that series would be a flexion shot and an extension shot. Patient would be asked to go through that motion, and then at the, as far as they can go back, they'd be taking that picture, and then forward, they'd be taking that picture. And at that point, you have a neutral, a flexion, extension, and now in the old days, 32 years ago, we may take those films and put them up on a view box and take a ruler and a pencil, a wax pencil, and try to measure out how much is slipped, in flexion or slid back in extension, how much angle has changed from one motion to, from one motion to the other. But what they found out is that it's too small of a difference that is important. If you're not getting maximum movement like that, you're getting millimeters of movement front and back. or degrees of angulation change are just like 3 or 4 degrees. It can make a huge difference, especially in the cervical spine, where there's so many nerves and so much going on in a tight spot.
Excellent. We're going to play a video right now. Please play video number 1 to kind of show what we're talking about here.
You injured your spine in an auto accident, or maybe you injured it doing something at work. Regardless of how you've injured it, now you're in pain. Most likely, you will have sprained your spine, which is an injury to your spinal ligaments. Whether you realize it or not, if the pain persists beyond a couple of days and you don't find the right doctor to take care of you, your life could take a turn for the worse starting now. You see, spinal ligament injuries can cause you to have permanent pain and instability, pain that can reduce your ability to do and enjoy the many activities that make life fun. So who is the right doctor to see, and how will I know what to look for? The doctor that specializes in treating these injuries or the chronic pain that comes from them knows that spinal ligament injuries cause abnormal or excessive joint play. These doctors know the more joint play there is, the more injury there is, and they're going to want to know where is it and how bad is it in your spine. These doctors take flexion extension x-rays or motion x-rays of your spine and send them out to have a specialized medical radiologist perform a procedure that accurately measures the spine for abnormal motion. With this information, they can now set up an appropriate treatment plan to reduce or alleviate the problem altogether and keep you away from the procedures that you may want to avoid. Look, when the spine's in motion, there should be very little joint play associated with that motion. So we see here a very minimal amount of joint play in the spine, and we can tell exactly where it is. So can the doctor. Where is it? It's mostly at C3 and C4, but it's minimal. Any combined pattern that's not over 1 millimeter of joint play is not considered excessive, and this is considered to be more mild sprain findings. Now, here we actually start to see more excessive movement. But where is the movement? It's very easy to tell. Anybody can see from this study, from the CRMA study, where is the excessive joint motion? Well, it's at C5 and C6. Here, we see excessive joint motion that's now crossing over beyond 3.5 millimeters of translation, and now we're starting to see more severe, more excessive joint motion. But again, the doctor can tell exactly where this problem is. How about this one? Well, this patient actually has a lot of excessive motion when they're flexing their spine or bending it forward. And when doing combined motions, the most excessive motion is actually in the upper cervical spine. How about this one? Well, it's the upper cervical spine. So it's very easy from these reads, from these CRMA reports, to be able to determine where and how bad the ligament damage is. This patient has excessive joint play or excessive ligament damage is indicated throughout the whole cervical spine. Now, this testing procedure is just as beneficial for those people who have low back problems or the lumbar spine as it is for the cervical spine. The enjoyment that you get out of the many activities of your life may be at stake by choosing the wrong doctor. If your doctor cannot tell you how to determine the location and severity of your spinal ligament damage, well, we'll leave it up to you to decide what that means. At Spinal Kinetics, we are the medical radiologists that take your condition very seriously, and we are here to help. If you need help finding a doctor that can accurately diagnose your spinal ligament condition, please call us or look us up online. Thank you very much for your time.
Okay, so Dr. Lambert, so the ligaments that get injured, as we just saw in that video, cause one vertebra to slide on top of the other. That's abnormal motion, correct?
Correct.
And that disc, which is between those vertebrae, that's getting rubbed on all day long as people move their necks, that leads to degeneration of that disc over a lifetime, correct?
Correct. And that type of, people don't realize it, but it's a big issue. It's a bigger issue than most people think, let me put it that way.
Yes.
It's probably the #1 cause of pain and disability worldwide. The amount of spinal ligament damage that occurs, the result of that.
It's funny because in the patient community and in the legal community, everything for years, and still today, because most people don't know about this, their gold standard are disc herniations. And you and I both know that if we take 1,000 people and we do MRIs on them, the people who have herniated discs, probably 40 or 50% of them have no pain. They're asymptomatic.
Correct.
Whereas this injury, most people don't even know about. And would you say it probably causes as much or more pain than most disc injuries?
It's probably because there's a lot more. It's a lot more common. And disc injuries are a part of ligament injuries anyway, because a disc is nothing more than a ligament. It holds two bones together, as you know. So it's it's part of it, and that's why it's when you put them both together, it's it's the number one cause of pain and disability around the world, and why it doesn't get more attention, I have no idea.
You know what's really neat is, like, when I have a patient come in, they've had a trauma, a whiplash, a fall, or whatever, and they come in and their MRIs are pretty normal. Most other professions will say, there's really nothing wrong with them, it's in their head. And then we'll do a ligament laxity analysis on them. We see bones sliding back and forth, ligaments torn, and all of a sudden we're like, now we know why.
Right, and for years, you remember back in the days when the patient knew they had problems, we knew they had problems, we just didn't have a great test to prove it with.
Exactly.
The lawyer, all they understood at that time were disc injuries.
Herniation.
If they didn't have it, then they would say, hey, I can't help you most of the time, and then the patient would be left with years and years of problems afterwards.
So don't you think, by us having this tool, I know for sure, that our treatment of our chiropractic patients is now much more specific and much more effective, because you and I, if we have a C5, C6 ligament tear and that bone sliding back and forth, we're going to stay the heck away from that area. And
certainly,
right?
In the beginning, for sure.
In the beginning,
at some point, the research has shown chiropractic manipulation to a hypermobile segment will help to improve the stability of that joint. By normalizing the mechanoreceptors, inhibiting the pain receptors, and by getting in the lumbar spine, the multifidi muscles, the ones around there, making them stronger and increasing their girth.
Right.
That actually is going to help stability. But yes, in the beginning, a doctor needs to know if it's hypermobile. They need to back off a little bit and use the more passive therapies.
Right. I mean, we have techniques that we've had for years called motion palpation techniques, where that's where we can actually put our hands on a vertebra and have the patient move their neck and see if that segment is moving too much or too little. Very subjective, very maybe it's their kind of thing, unless you're highly skilled in that palpatory technique. But now with this technique called ligament laxity analysis, we're able to see an exact measurement after an analysis and see exactly how much slippage there is, and if it's within the normal amount of movement or if it's outside the normal amount of movement, correct?
You and I both think the same way, is that the less guesswork we have to utilize with this, the more objective evidence we have, that the more specific our treatment can be tailored to the patient and the better outcomes.
Okay. So you, the patient, I think you may want to check to see if your chiropractor you're seeing is utilizing these techniques, if you've had a car accident or a trauma. If not, if I was the patient, I would want to make sure that if I have an unstable segment, that my chiropractor knows about it, so that he can give me the best treatment possible. Is that right?
Yeah, it only makes sense. Why not?
Right. Tell the audience how they can get in touch with you if they have more questions about this type of testing, your office, your website.
Okay, my office is located at 2805 Veterans Highway. That's in Ronkonkoma, New York. You can get me by phone if you need us at 631-738-8300. And my email address is drjlambert, which is LAMBERT, @AOL.com. I'm the doc that still has the AOL address.
Well, Dr. Lambert, I want to thank you very much for joining me on the show.
Thanks. A lot of fun.
You're going to be
Appreciate
here
it.
for part 2, and we'll discuss in a lot more detail this great new testing technique.
Sounds good. Thank you.
For those of you watching us on Madhouse TV, stand by. We'll be right back. For those of you watching us on Cablevision, we'll see you next time. And remember one thing. If what you want is real wealth, join us next time on The Bridge to Health. If you're watching us on Madhouse TV, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
you're watching it.
Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. And today we have returning Dr. James Lambert. Hi, James.
Hey, nice to be back.
Good
Thanks.
to see you again. So, on our last show, we spoke about soft tissue injury. We spoke about kind of what you're specializing or focusing in right now, which is a injury called ligament laxity, and a test which we now, thank God, have to our avail to use as practitioners, which helps us document if ligaments are torn and if spinal segments are unstable and not moving properly.
Yes. Mm-hmm.
Okay. So when a person has a car accident and they go to the emergency room and they're assessed by either an MD or a PA, and they have x-rays taken, what are the standard x-rays they would have taken in a hospital after a car accident?
Generally, a trauma set of films involves, in the cervical spine you're talking about, I imagine. At this point, right?
Yeah, let's start with the neck, cervical spine.
They'll take an AP scout film. They'll take a lateral. They'll look at an AP open mouth, which is to look at the upper two vertebrae in the neck. They'll look at a flexion extension film, which are the ones that we incorporate for this ligament laxity testing. That's incorporated in a normal Davis series. They also look at the obliques to be able to look down the IVF to see if there's any nerve root entrapment that way.
Mm-hmm. So, and what x-rays additional to those would you add in your clinic for a patient who comes in with a neck injury?
Well, if that patient comes in with a neck injury and also has headaches, I would also take a lateral bending film. You know, if you can imagine a film coming right through my mouth, seeing those upper two vertebrae in my neck, I would take that with being bent to the left and bent to the right to be able to see if there's any amount of slippage in those upper ones.
Between C1 and C2?
Between C1 and C2, yes.
And that is so important because that's not an x-ray which is normally taken in an ER or an orthopedist's office, because what that actually shows is if this is the ring of C1 and C2 sits inside that ring and C1 rotates around it like that, that if the ligaments that hold these two bones together are torn, isn't it true that that first cervical vertebra can actually move and put pressure right on the cord, right?
It could be as bad as causing, complete cord rupture. It could cause, it's a major injury, and it's something that is not looked at as often as it probably should be, especially if a patient, you see football players that come off the football field, and when they really think that there's a significant neck injury, what do? They put them in a hard collar, they put them on a board, they bring them there, bring them to a hospital, emergency room, take x-rays.
Right.
Hopefully, at least in those cases, they're looking at and taking those films too. As a standard protocol, those films are not taken, and they really should be.
Often we have patients come in who have been in whiplash-type injuries or falls or whatever, and they hurt their neck, and they're in such bad shape when we first start with them, they really can't move much.
Mm-hmm.
So we take these films, and if we don't have much flexion or extension because of all the spasm, we're taking those films just to rule out fractures, dislocations, real serious injuries, so we know where to go from there. So what we do is we'll rehab them for a little while, we'll decrease the spasm, and if in a few weeks they get normal range, better range back, we'll then repeat a couple of shots to see if there's ligaments damage and if the bones are slipping. Is that correct?
Yeah, it doesn't have to even be normal range at that point. The patients you're referring to, and it probably doesn't happen as often as a lot of people think. Maybe about 20% of the time, initially a patient will come in and they'll have like no motion, inflection or extension.
Right.
And so if we look at those X-rays, the initial X-rays, that when the patient came in, and everything is moving as one big block.
Right.
You're right, that those have no value and they have to be retaken,
right.
The flexion and extension films. But if we can see that the patient has even a bit of motion in each of those segments, we're able to tell if there's enough slippage there
right.
or enough change in angulation.
Right. I know the answer to this, but I'm going to ask you the question anyway because I want the audience to understand the answer.
Okay.
So somebody in the audience has a car accident today. They go to the ER, they're in severe pain, the ER releases them, they follow up with your doctor. And now they come to us, and they've heard about this new technology.
Mm-hmm.
How do you know that the ligament rupture isn't so bad that if you actually have them bend their neck down or bend their neck back, that's not going to do more damage?
I'm sorry, just say that one more time,
Okay.
the last part of the question.
If somebody has a very severely ruptured ligament,
Mm-hmm.
and now we ask them to bend their neck down, and that slippage is so bad, it might cause more damage just by doing the films.
Mm-hmm.
How do we know it's okay to do that test? From clinical exam, right?
Exactly. The orthopedic findings, there's a couple of tests I won't bore the audience with right now,
Right.
but there's some tests that are done, and that rules out if there's any signs of instability, if there's any signs of, if a patient's asked to flex their neck forward, and they get these shooting pains going right down their neck,
Right.
we're not going to go ask them to maximally flex their neck or go back in extension.
Exactly. I just wanted you, the audience, to understand that when people are in severe traumas and they give them collars, they bring them to the hospital, they may send them home with a collar, we're not going to go and stress their joints just to see if we have any findings without doing a thorough clinical exam, orthopedic exam, neurological exam to rule out any injury that might occur if we do that. And if we do see that, they're referred straight out to an orthopedic surgeon
Mm-hmm.
or a specialist when those big red light signs come up. But it doesn't happen that often. It's
No.
very, very rare. Thank God it's very rare.
Right, or, I think in our, like we said, we've been in practice over 30 years. In the times that we see that, it's always been very small. 1% of those that come in are clinically unstable that have to be sent out immediately to, at least to rule out a more serious condition. So.
Okay, we're going to see a short video right now. Please roll video number 1 for this show. That would be A2.
When we're talking about a spinal soft tissue injury assessment as a doctor of chiropractic, we're usually talking about a spinal sprain assessment. So a spinal sprain is any time you injure any aspect of the spinal motion unit's ligaments. There are 10 ligaments: the anterior longitudinal ligament, the posterior longitudinal ligament, the disc, 2 intertransverse, 2 capsular ligaments, ligamentum flavum, an interspinous ligament, and a supraspinous ligament. Damage to any of these ligaments is considered a spinal sprain. Here's what the International Chiropractic Association policy on spinal sprains says. It says inherent. In inherent, we must qualify means existing in someone or something as a permanent and inseparable element. So inherent in most spinal sprain strain injuries, there exists a biomechanical neurological component of articular malposition referred to chiropractically as a subluxation. Let's stop right there. Inherent means that they coexist. You can't have one without the other. So if we can measure, grade, and locate the severity of a sprain, we can measure, grade, and locate the severity of spinal subluxation. This also goes on to say, such subluxation, if not addressed and merely treated with soft tissue therapeutics or joint immobilization forms of care, may lead to joint fixation or instability and loss of motor unit integrity. Now it goes on to state, it is the opinion of the International Chiropractic Association and that such injuries evidence of the chiropractic vertebral subluxation complex should be analyzed and, if present, be corrected by specific chiropractic articular adjustments before immobilization procedures are applied. Lack of such correction of articular misalignment may result in permanent impairment. For waiting more than an hour, much less days, may lead to joint fixation, motion impairment, neurological insult, and or hypermobility of the intervertebral motor unit. Adjustive reduction of the articular subluxation must be accomplished with due regard to the soft tissue injury. Attempt to enhance recovery and contribute to the prevention of future joint motion impairment, neurological impairment, and deteriorative pathological consequences. Okay, so what is that saying? Well, it's basically saying that inherent in a spinal sprain is a spinal subluxation. You need to locate that spinal subluxation and correct it right away. So when we have a sprain, we know that we have a hypermobile situation usually. Now, we may have, due to pain, spasm, inflammation, a hypomobile palpatory finding, but we know if we've damaged the ligaments hold the spine in alignment under load, that radiologically we probably have more of a hyper situation. And this policy is saying that the chiropractic spinal adjustment is the key to stabilizing this condition. Again, ligament sprains commonly occur, can be quite debilitating, frequently causing persistent joint instability, prolonged pain, progressive degeneration. A sprain is defined as an acute injury to a ligament or joint capsule without dislocation. Sprains are classified by severity. Grade 1 shows no clinically detectable increase in joint laxity. Grade 2, you start to see detectable joint laxity. Grade 3, significant joint laxity. We know that significant or joint laxity, and trying to determine this on X-ray, has already been proven out in research to be most accurately and reliably determined with computerized radiographic mensuration analysis. In this study presented in 2007, 6 board-certified medical providers who commonly read flexion extension X-rays were asked to use whatever tools that they normally use currently to determine the abnormal intersegmental motion in a particular study. Using whatever tools, those tools could be their PACS system, picture archiving and communication system, and all the beautiful measurement tools that they have available to them in those systems. It could be them using just their eyeballs. It could be wax templating. It could be drawing on their screens. It could be anything that they normally would use. Now, when they were given 10 minutes of training on a computerized radiographic mensuration analysis system that's designed to help them pick up the abnormal intersegmental motion, and they put the same 65 sets of films, 75 sets of films back through, they had a 77% agreement level as to where the abnormal intersegmental motion patterns were. whereas previous to that they only had a 17% agreement level. So significant improvement, and of course the 77% is going to go up a lot if the providers have a lot of familiarity with the system that they're using. Again, they only got 10 minutes of training on this system. So let's take a look at this. We have a normal, neutral, a flexion, and an extension, which is what we need. We pull up the report. We immediately drop down to the report. We look at the lateral cervical spine. We see there's no break in George's line, and we see that everything's below rateable. There's no significant joint laxity here. But we also can go right down into the impressions part, and we can see for angular findings and for translation findings, all are within normal limits. This is a grade 1 sprain finding on radiograph. Now we go to this one. This is a DMX, another form of taking an X-ray, and here we have the patient in a flexion and an extension. We pull up the report, and the report simply says, look, again, on the lateral cervical spine, George's line is within normal limits. On the cervical motion study, we don't have anything that's rateable or significant, severe, but we do have, and when we say significant or severe, moderates can be significant clinically. We're just saying significant as far as a radiographic finding. It's saying that basically we don't have any rateable, but it does, we can go down now into the body of the report, and it shows that we definitely have ligamentous laxity or joint laxity detectable on X-ray finding now. So in this case, we have a grade 2 sprain. In the last scenario, we pick this up, we take a look at the test, and we immediately see right in the cervical motion study that we have a rateable angular segment at C3, which means that basically we have a severe or a significant sprain finding, significant joint laxity, grade 2 sprain findings at C3. And that gives you the readout of the angular finding that qualifies it. So we can definitely become a lot more objective in our sprain or soft tissue injury analysis. You're in an accident you simply could not avoid, and now your spine is injured. Don't make the second accident choosing the wrong doctor to help you. When it comes to spinal ligament injuries, this second accident can be the most damaging accident you could have. Spinal ligament injuries can be painful, progressive, and permanent. Those that suffer these injuries and have chronic pain from them still today know exactly what I mean. Today, doctors that specialize in this condition know that spinal ligament injuries can be comprehensively evaluated using functional diagnostic imaging procedures called functional X-rays and computerized radiographic mensuration analysis. If your doctor does not know the severity and the location of your ligament injuries, well, we'll leave it up to you to decide what that means. But a lifetime of avoidable pain and discomfort can be a really long time. At Spinal Kinetics, our board-certified medical radiologists help your doctor to identify your spinal ligament injuries so that they don't go undetected. And as with any condition, early detection is the key to better correction. If you need help finding a qualified doctor in your area, simply call the numbers on the screen or look us up on the internet. Thank you.
On Madhouse TV, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
If you